And finally, I'm just going to mention that there are a few other serious complications that can occur. You're monitoring a patient who's had a lot of fluid in the OR, but at the same time has had a lot of bleeding. Sometimes, if someone is hypervolemic or hypovolemic or anemic from blood loss, you can have electrolyte imbalances that can cause dysrhythmias. Patients who already have heart problems or potential for heart problems can go into things like flash pulmonary edema. They can go into congestive heart failure because of all the extra fluids if they're real close to having problems with that anyway. They can have, severe perfusion problems. They can have neurological deficits that don't resolve real quickly. And so, it's just globally important to recognize the immediate post-op risk as well as additional things. We've already talked a lot about the patient's development of atelectasis and how you would, really want to have the patient use incentive spirometer to prevent pneumonia. You also want to do good mouth care to prevent pneumonia. And, you want to, not give too much pain medication to over-sedate a patient or cause additional problems. But at the same time, you do want to treat medication. Other complications can be extreme nausea and vomiting, as I've mentioned before. Whether they've had a history of that or not, this might be the one surgery that causes that. Imagine if you've had your abdomen cut into and had some kind of GI or GYN surgery, and then now you're so nauseated and trying to hold an incision and throw up. That can be extremely tough on a patient. So just kind of be thinking about, and you might want to make yourself a list because really when you think about it, when we're thinking about monitoring these patients and you want to be prepared for, say, the top 5 complications that could occur and know exactly what kind of actions that would be immediate and then maybe secondary actions of what you would want to do to help solve some of those complications. Laboratory assessments are nearly always done. If someone's had bleeding and had a lot of fluids, you want to make sure that there is an analysis of their electrolytes from a fluid balance standpoint. You also want to have a CBC post-operative to look and see has their hemoglobin dropped. And sometimes you'll see that not happen immediately in the PACU, but usually on post-op day 1, they will draw labs on the floor to just see and track that. So that's a key thing to get in report and or look for the most recent baseline data on the hemoglobin because you want to be tracking that in an ongoing way post-operatively to make sure there's no unexpected drops in that. Sometimes specimens may be sent for culture if somebody's really being monitored very closely from a respiratory problematic standpoint. They may have blood gases drawn. Additional urine tests might be sent on someone. Diabetics are often monitored for glucose on an ongoing way through surgery. And because they want to keep the glucose level down post-operatively on most patients, any large surgical incision type cases anymore, they will have them on post-op glucose checks and even sliding scales for non-diabetics because they want to keep their blood sugar levels down below 140. They have found in studies that actually is associated with decreased surgical infections. So, you may have to explain to a patient, why am I, potentially getting insulin? I'm not a diabetic. That's really the reason why. Of course, we know that the patient is potential for hypoxemia. Highest occurrence is on the second post-op day sometimes. Some of this is due to atelectasis and the effect that anesthesia has had on the lungs. And so these are our key interventions: airway management, monitoring, pulse oximetry, keeping them in a semi-Fowler position, providing oxygen and breathing, turn, cough, and deep breathing exercises, incentive spirometry, and then mobilization as soon as you can get them up and moving. And often they don't want to participate in that, but you still have to push for that. We're also monitoring the renal system. We're checking for urine retention. A lot of patients will come out with a Foley catheter from surgery, and after the first day or so, they'll remove that because we're, of course, trying to prevent CAUTI. And so then you will monitor them for the first 4 to 6 hours, depending on your order, to determine, have they voided on their own. If not, you may want to go do a bladder scan just to see if they're retaining, and then notify the physician if there's a problem, either with low output, period, or inability to void and urine retention. Also, you want to watch fluid loss from things like sweat and vomitus and diarrhea post-op as well, and monitor and measure that very close. Anytime you have urine output less than 30 mLs an hour over like a whatever period of time that you're monitoring that, average that, then you need to make sure that you notify the physician. From a GI standpoint, like I said, they may have a lot of nausea, vomiting. 30% of patients experience that problem with general anesthesia, so it's very common. They may have peristalsis, which means that their gut kind of is delayed in starting back up its musculature action that helps move stool through the bowel. So you want to monitor the bowel sounds. You also want to decrease nausea and vomiting, and these are 3 very common ways or medications that can be given for that. Zofran is almost 100% commonly ordered for everybody that comes back from post-op, and it's given IV early on and maybe later transition to a PO form. Some patients with severe history of post-op nausea and vomiting may have a scopolamine patch put on before they even go into the OR to kind of help manage that as well. There are also potential for infection and delayed wound healing. Dressings, the first change is usually done by the surgeon, so you don't want to go taking things off or messing with it unless you have an order to do so. For drains, you really want to make sure that there's an exit route for the fluids to come out, because if for some reason a drain gets clogged, then there's potential for the fluid to pool in the cavity where it's draining, and you can develop an abscess and problems with healing from that. So, and it helps prevent infections to keep that. So if you have a long period of time where a drain's not drained, and it's pretty early post-op, you definitely want to notify the physician. In some types of drains, the doctor may need to come and milk it or give you instructions to irrigate a drain to see if it's just stopped up a little bit, to see if you can get it draining again. So it just depends on the particular drain. Again, some drug therapies can be given. Sometimes if there's a problem with the wound and it's not healing well, the doctor may need to come and cut away some of the dead tissue, and that's called debridement. And then, if a wound opens and you have a dehiscence where it opens up, you may have to have additional treatments and maybe a wound vac to seal that back. These are just some common skin closures that you may see. Obviously, until the dressing comes off, you won't see a whole lot of that, but sometimes in reports you'll be told what type it is that's under that. But you want to follow that and make sure whichever one it is, and staying the site. You'll document when it has the dressing removed. You'll start documenting exactly what the wound looks like, that staples are intact, if there's any redness, any bruising, those kinds of things, and or any drainage or oozing from any of the areas of the incision. Here's just to kind of let you know what one can look like. If it opens up, you can have a dehiscence, which is just a kind of a superficial opening, and then evisceration is when you literally have the bowel protrude through, which is a serious, either one of those are a very serious complication, and the doctor needs to be notified immediately after you cover it with a, wet saline dressing just to keep it covered. Often those will have to be put on a wound vac to kind of vacuum seal and bring those back together over time and heal slowly. These are just some other things. You may have some drains that come out of the skin. Some people will have this lower drain called a Jackson-Pratt drain that has to be set to suction, and there's a specific way that you do that. And this is just another example of, for abdominal areas to close, sometimes they'll have a dressing that actually ties, that's called Montgomery straps. So just look through the rest of your information in your textbook, and if you have any questions, let me know, and we'll talk a little bit about a case study of a surgery patient on Tuesday.